So thank you again from another hat. And thanks again for picking this topic on stress and PTSD. And congratulations to the conference organizers for, again, putting up such an impressive conference. It's not the first time that I'm attending this conference, and I hope it'll not be the last time either. And as the Mesut said, I am very happy to formally introduce that I will be the International Representatives President for the meeting in April 2020, which I have gladly accepted last year. So thank you very much. It's an honor for me. So in the next 15 or so minutes, I would like to introduce a new idea that is called staging in PTSD. Now, this is my hospital where I work. It's a front view of Leiden University Medical Center. It's a very old university town in between Amsterdam and The Hague. It's a very old university, and part of that university is our hospital. This was me just to remind myself of my relatively recent past. I used to wear the uniform that, as I was in that chair, I would have introduced myself. I have been in the military for 20 plus years, and I was the head of research in the military mental health care. And as such, I was dealing with post-traumatic stress disorder, which was my topic of my research and my clinical activities. And I'll be speaking from that hat to you. So the military hat has been my focus towards post-traumatic stress disorder that we all know also occurs in civilian life. It is not exclusive for uniformed professionals, but the uniformed professionals, especially in the military, are at high risk of being exposed to traumatic stressors and therefore have a likelihood to develop post-traumatic stress disorders with an S at the end. Now, this may be a picture that is familiar to you. It was broadcasted just last year with the earthquake that happened in your country and in Syria. And when I look at this picture, of course, it may touch us because of the emotion that is conveyed on the face of this individual. But we may also take a more distant look and wonder, how would this person be doing now? In other words, what is the trajectory of, if there is recovery, of the impact of this, what we can call a potential traumatic experience? How would he be doing now? Would he sleep well? Would he be mourning the loss of so many of his loved ones? And could we have predicted in what category, if you can call category, he would fall under? Resilient or PTSD? Now, briefly, what is a PTSD diagnosis in 2024? On the left here is a lot of text that says the etiological component of the trauma. It has to meet any of these things, directly witnessing, etc., etc. And then we have the symptoms, the intrusions, the reliving, the avoidance and the numbing, the alterations in cognitions and mood, and the hyperarousal and irritability that are, as colleagues, as psychiatrists or clinical psychologists, we assess them in our patients and then can categorize or label somebody. And the disorder has an impact on so many functional domains that we'll hear more about. Stress regulation, memory, cognition, emotional regulation, and in some dissociation. And we see that particularly in the ones that have early childhood trauma that later in their life suffer from dissociative episodes. Now, you may think, hey, Eric, this slide doesn't fit in. Well, it is exactly the message that I would like to convey to you. We know in medicine, breast cancer, right? It's a disorder that is very prevalent in women. We also know that a common way to look at breast cancer is from a stage-oriented perspective. It's very important for a female to be looking at what is the stage of my breast cancer diagnosis. Stage 0, 1, 3, or 4. And it tells something about the spread of the disease. And not only that, the spread of the disease also is connected to the treatment of the disease. So if you're in treatment 1, the surgeon will have a different treatment scenario than when you would be in treatment or in stage number 4. Now I see you nod, and this is probably a no-brainer, and actually that is the take-home of my message. Would it be helpful if we looked at PTSD through the same lens as we do for breast cancer and other medical disorders that we emphasize as a stage orientation for the diagnosis and looking at the spread of the disease, and also having an impact on the treatment trajectories? So if you keep that in mind, now this is what I said about the treatment, where you are, and in red are the different treatment regimes in every stage. Now, we won't delve on that, but this is the frame for the rest of my presentation. So when we look at PTSD, we could look at PTSD through a same lens. And together with a dear colleague of mine, Miriam Mink, she's a clinical psychologist, she's a healthcare psychologist at our National Psychotrauma Institute, ARC, in the Netherlands, and Sandy McFarlane, who's a professor of psychiatry in Adelaide, in Australia. Typically on a conference like this, we went for a coffee during the breaks, and that's how that idea emerged, to look at a stage orientation in PTSD, and ultimately we wrote it up as a paper that is now out. And it started as an idea, and then we were wondering, like, what is the evidence for that, and what is the benefit of looking at that? So stage 1 would be the person that I just showed you. He was trauma exposed, and when you're trauma exposed, you may be at risk of developing PTSD. Then stage 1 would be you don't have any PTSD symptoms, you can have sort of undifferentiated symptoms, mild anxiety, distress, or subsyndrome. You don't meet the criteria for PTSD, but you're not doing well. From stage 2 on, we would say then you have PTSD, because that's the first episode of PTSD. It could be a year later that it's diagnosed, it could be 5 years later, but still, it will be stage 2. Then you would go in a treatment regime. You get EMDR, you get medication, etc. You will respond, you may not respond to treatment, you may endure in relapses, you may become chronic after 10 years and are still struggling. Well, then you may be talking about stage 3 or stage 4. Stage 4 would be somebody who's been in treatment, who's been relapsing, and after 25 years would still meet criteria for PTSD. He would have maybe grown obese, his hippocampal volume may have shrunken, there may be a lot of biological alterations that have contributed to the wear and tear of having a chronic disorder. And then you may not do EMDR in somebody who's been 25 years in PTSD. There have been many attempts already done with EMDR, and he's failing to report. So we propose that it may help a biological profile of the disorder, as well as, similar to the breast cancer diagnosis, tailoring treatment. Now, this slide was the one that I was exposed to almost 20 years ago. Bob Post is a neuroscientist at the NIMH, the National Institute of Mental Health, in Bethesda. And when I was in the audience 20 years ago at the ISTSS meeting, he showed me this slide. I think it's brilliant. It already gave us a time trajectory of the disorder. And if I can do this, here you see the time trajectory, right? This is time here. And here you have the traumatic event. It could be the earthquake, it could be whatever. And then you see here in the immediate aftermath, you have this stress response, traumatic arousal, maybe on top of that some dissociation, and you have here some biological correlates. And as time progresses, and we often see that in our patients, we may see here the nightmares. Here, we may see, as time progresses, explosive anger, right? Alcohol, substance abuse. It doesn't start here, but it may grow into it. And we may see what he portrays here as, let's call them negative symptoms, numbing here, depression, social phobia, self-mutilation in some, and that is here depicted also as on a time trajectory. So there are temporal characteristics of a PTSD response. Now this is a couple of icons that resemble PTSD. What is PTSD in a nutshell, right? But when you look at these don't all occur at the same time, all at once. The one that stands out is in the middle. That's probably the first one where PTSD starts with. It starts with a flashback. And from the flashbacks, if you have these flashbacks and these nightmares occurring, then there may be sleeping difficulties, there may be bad dreams. And then, logically, you start to avoid, trying to get avoidance of these memories. You try to avoid talking about it, trying to avoid it, going to places. Or you may ultimately be feeling guilty about what you have not been able to do or what you have done that didn't succeed. So there is a temporal orientation in the occurrence of these symptoms. Whereas as doctors, psychiatrists, we checkbox them, PCL, boom, 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 boom. But we forget about the temporal dynamics. When you look at a large group and you do the PCL after an earthquake or another traumatic event, you may get all these, let's say, trajectories. Right? Some have symptoms in the beginning, others go back down, and others have a delayed response, others fluctuate over time. So you see an array of responses. Okay, that's fair. If we look at a stratified cohort of soldiers that we sent to Afghanistan, and I was in the military, so I conducted a study where we followed 1,000 soldiers before they went to Afghanistan in the ISAF, the International Security Assistance Force, in 2005. And what you see here is what happened to them in the first 5 years. So we sent them out here, and then we did a baseline assessment. How are you doing? Are you doing okay, doc? PCL5 or the CAPS. And then we followed them up in time over 5 years here. And then when you have a look at trajectories of these 1,000 soldiers, and Afghanistan was not an easy war. Fighting the Taliban, acts of commission, there were a lot of casualties. It was high risk, and almost all of these 1,000 soldiers had been exposed to a type A criterion, which puts them up for a potential disorder downstream. Now, the green ones, 85% were resilient. They said, "Doctor, I'm still fine, no symptoms, I'm okay." Interestingly, there's a red group that reported symptoms in the first year. They meet criteria for PTSD, but if you follow them on time, they recover. They go into almost back to baseline. That represents about 5.3%. And interestingly, that's still a puzzle for me, but that's fine. There's no response in the blue group, but after 5 years, they start reporting symptoms. It's a delayed group. So they wait to report. There may be stigma. There may be a biological correlate why they respond so late. And you may wonder, okay, is the treatment different for the ones that report early symptoms versus the ones that report late symptoms? Maybe these ones need to have EMDR. Maybe the ones that report later symptoms, they may do better with other treatment reports. Think about the breast cancer analog, right? Maybe it could help us. This is actually, it's a very busy slide, maybe if you look at it, a similar slide taken from a whole different cohort. Maybe you remember the Fukushima earthquake, right? It was an earthquake, nuclear attack, and a tsunami in the northeast of Japan. And with the next presenter, Floor van der Does and myself, we have been happy to look at 50,000 first responders in the first 8 years, how they responded to this incident. And you see the same trajectories. It's not unique for the Netherlands. If we did it here in Turkey, we'd have the same trajectories, that some report with a delayed profile, some with an early profile, and some with a resilient profile. Just to show us that there's not one orientation to the temporary characteristics of PTSD, but there's a difference. Now, I will not talk about this in extension, but this is just to refer to Floor van der Does, a PhD student at Leiden University, who will talk about how we can take this even a step further, and we can look at how these symptoms hang together, so to speak, and how they hang together in this temporal orientation and what it can help us. Because network analytic approaches are conveying a lot of new information that yield very important components for therapy. So this staging model, now yes, this is busy, but it is what it is, and this comes from the paper that we produced in Acta Psychiatrica. Here are the stages that I just familiarize yourself with, right? Then this is here what I just walked you through, here. These are the possible neurobiological markers of the stage. What we propose in the stage 1 and the stage 1B is a different neurobiological manifestation of the disorder than when you look at stage 4. Here you see a word that I just wanted to read here, high allostatic load. Allostasis is something that was conveyed by Bruce McEwen and others, and reports something that is you're holding a balance, but there's a price to the balance, and maybe there's a break. That's the allostasis. Well, if you're in stage 4, there's almost that moment of breaking the allostatic balance. There's an equivalent information processing symptoms equivalent to the staging. And there is a psychophysiological stress and emotional reactivity in consciousness. Now, it's a lot of text, but I just wanted to get you the idea behind this. And then you may wonder, like maybe there is an intervention strategy that is best suited at that different stage. Maybe in stage 1, we need to have a different arsenal or repertoire of interventions than at stage 3, A, B, C, or maybe stage 4. Maybe in stage 4, we look at physical management of comorbidities. Maybe we look at moral injury in the case of a moral injury subtype of PTSD, or we look at preventing comorbidity. So it's a different orientation to the interventions than when we look at stage 2 or stage 3. This would be very helpful if we had markers for all this, right? Is there a biomarker for 2, 3, and 4? I just wanted to convey to you, biomarkers is a buzzword, but there's a very heterogeneity amongst biomarkers. You have an array of risk markers, secondary risk markers, disease markers, therapy markers, susceptibility markers. So we need to be more specific when we talk about markers that are specific for each stage. We're not there yet. I'll skip this in the interest of time. Yeah, typically, and I'll start to wrap up here, is I'm a consultant for the United Nations as well. And in the United Nations, we're sending troops to peacekeeping operations. Many countries do that. I think Turkey and Egypt and Nepal and India and send troops. And what we convey to the peacekeepers, they're typically a year deployed. And we talk to them about their mental health approach, and we talk to them in terms of colors. If you're green, you're okay. If you're yellow, you're so-so. If you're orange, you're not doing really well. And if you're red, you need to seek assistance, right? If you're in a peacekeeping area or so, you get a hit, an impact, an impact, an impact. And if you don't bounce back to green, you may be in need of being helped. Now, what if somebody could monitor their own color code as they're in the deployment area, right? And they say, hey, I'm 3 weeks or 3 months into deployment, I'm red. So then you may see where you are in the stage of what are the trajectories of stress responses. You can monitor your own stress response trajectory. Now that will be helpful, and what Andy Greenshaw told us yesterday, like, hey, then you could look at a reflective mirror, like, how am I doing in time, right? And you could sort of, based on what you see, get help. And of course, a picture of the brain, but to just demonstrate that's all in the brain. And the allostatic load model, actually, yeah, just to justify, I came from an era where we looked at hippocampal volumes, and that's kind of the biological marker of PTSD, and that comprises so much of the allostatic load, right? If you have a smaller hippocampus, that is the biological marker of PTSD. Probably it's been there for a long period of time. And Harm Krugers will talk about that as well more, I think, Harm, where the memory is stored in the hippocampus and how vulnerable the hippocampus is for the later life trajectories, and maybe that's a basis for where everything can sort of be explained from. But just one highlight, if I don't go over time too much, I just want to explain this slide, this one here to you, to talk about the allostatic load. What you see here are 3 lines. You see a yellow line here, a blue line, and you see a red line, okay? This is the beginning of the evening, and this is 8 o'clock in the morning. This is the heart rate of a group of veterans that are sleeping in a hospital. Just heart rate. So the blue ones are the trauma controls. They don't have PTSD. They have not been deployed. The healthy controls trauma controls. They have been deployed, but they don't have PTSD. The healthy controls are the ones that have not been deployed and have no PTSD. But the red ones have PTSD and have been deployed. Now, the blue and the yellow ones are having a heart rate of about 67 beats per minute. You feel like, okay, that's fine. A heart rate for 67 beats per minute, that's fine. But the red ones have a heart rate that's slightly higher than the other 2 groups, 6-7 beats per minute. Now, it always puzzles me, if you're sleeping, you're at your base heart rate. Why would you sleep and have a heart rate that is 7 beats higher? Because the set point is elevated. And that's the biological marker of PTSD. So that's the allostatic load evidence that the thermostat is upregulated. And if you have that one night, that's probably fine. If you have that 1 week or 8, but if you have that year after year after year, it does the wear and tear on the cardiovascular system. So again, that's what I hope that you will take home, that there may be analogous to the breast cancer, an idea to look at PTSD. And of course, this is only 2 years out, so we need to have more ideas to discussion and what's the pro and the cons of this. But I just wanted to tease you with the idea, if it helps us to do our biological research and to have an orientation on treatment interventions. Again, based on the work of Bob Post. And if you want to read more about this, there's a wonderful review article by Lisa Burback, coming from Andy Greenshaw's group of Alberta and Edmonton. It's a state-of-the-art review where we also flesh out this idea of a stage orientation. It is in the paper Current Neuropsychopharmacology. It's open access, so it's free downloadable. And that's Lisa Burback, a wonderful colleague psychiatrist who was here last year. And with that, I would like to thank you for your attention and take questions.